welcome to this last resort revision session of dermatology. So, are you able to see me? Are you able to hear me? Give me a few thumbs up so that we know that we are live and all our connections are okay. So first of all, my apologies because of some technical error, the session could not be started on the right time. And despite best of our efforts, it got delayed. But here I am, and we'll still be discussing dermatology today so that your day is not wasted. And the day which was assigned for dermatology, we'll finish it here. So I hope there are no more glitches, and I hope we are able to conduct a smooth session. So just, so no audio. Rahulji, are you not able to hear me? So, some of you are saying that volume is low. I hope volume is very less. Just give us a second. It's better now? Do you think it's better? I'll only start when you tell me that. Yes, sure. You can also see it for FMGE. There are only, it will only help you. That's completely fine. We are just working on the volume. So meanwhile, I'll just brief you on the session that we would be conducting. So this is last resort revision. This is basically more of an image-based discussion on previous year topics. So I'll be showing you some images. I'll be discussing the important questions which are asked from that topic, since we know that dermatology is mostly image-based and there are a lot of clinical questions. So we'll quickly go through them. It will not be possible for me to cover things in great details. So I will quickly revise most of dermatology, which I think is important for you. However, if there are any doubts which are there, please put it in the chat box related to topic. I'll try to clear them then and there. However, if I've not covered any topic and you want to clear that in the end, we can do that also, right? Oh, no, I'm not shouting, I'm sure. Fine. So let's start, and I hope most of you are able to hear me. In case you still have an issue, you tell me. So as in dermatology, we always start with basics. So basics in skin, you should know about the layers of skin, which I'm sure you all know. Come, let's get sunburnt. Corneum is the topmost layer. Stratum lucidum, just know it is only present in palms and soles, and L for lucidum, L is palms and soles, and this is a clear cell layer because of refractile granules of LED, right? Below that is granulosum, spinosum, basal and dermis. Stratum basal is my germinative layer. You should know that if this is the layer from which my whole skin is being made, right? So important features: stratum corneum is the dead skin layer. It serves as a barrier function. Lucidum, I told you. Granulosum has two granules, predominantly the keratohyalin granules and odd-land bodies. Stratum spinosum is the layer where you see desmosomes. Predominantly desmosomes are present all over, but predominantly you see it in spinosum. Photo ke width kam kar do. Stratum basal, as I told you, is the germinative layer, right? Now, what is this epidermis made up of? This epidermis is made up of four cells, four types of cells. These are keratinocytes, melanocytes, Merkel cells and Langerhans cells. Now, quickly, important points to remember: keratinocytes are derived from ectoderm, and they are present in all the layers of the skin. So, almost 90 to 95% of my epidermis is formed by keratinocytes, which help in the barrier function of the skin. Clear? Next, both M's, which is my melanocyte and Merkel cell, both M are derived from stratum basal. So stratum basale has melanocyte, Merkel cell and keratinocyte. This is a question which is asked, that which cell will not be seen in stratum basale. So this is stratum Langerhans cell, which is present only in stratum spinosum. Right. Now coming to melanocyte again. So melanocyte is derived from neural crest. This is responsible for pigmentation. This gives color to the skin, and this melanocyte transfers its melanin to 36 keratinocytes around it, which is known as epidermal melanin unit, and this EMU is responsible for uniform skin color. Clear? Neurocutaneous, yes. Thank you, doctor. We'll look into your input, and I will tell the staff to work on this problem. Thank you so much for your input. Coming to Langerhans cells are my antigen presenting cells. These are antigen presenting cells which are derived from mesoderm, and they are present in stratum spinosum. Now Langerhans cells have Burbeck granules, and these are dendritic cells. These are dendritic cells. Now Merkel cells. What are Merkel cells? Merkel cells are slow adapting touch receptors. They are slow adapting touch receptors, and they are present in stratum basale. They are present in stratum basale. There is a similar sounding cell which are called as Meissner's corpuscles. They are also touch receptors, but Meissner's corpuscles are present in dermal papillae. Don't get confused. So Merkel cell in stratum basale and Meissner's corpuscles in dermal papillae. Clear? So layers of skin is important, types of cells are important. Now coming to few changes that you see in my pathology slides and that are asked. So one change that you see is called as parakeratosis. So we all know what is parakeratosis. So parakeratosis is retention of nuclei in stratum corneum. Retention of nuclei in stratum corneum is called as parakeratosis. Normally my stratum corneum is devoid of any nuclei. There is no nuclei there. But if we see nuclei, it's called as parakeratosis, and this is seen in different clinical conditions remembered by the help of mnemonic PEASE-2. Psoriasis, eczema, actinic keratosis, and seborrheic dermatitis and SCC. So these are different conditions where you see parakeratosis. Commonly they asked you about actinic keratosis. Parakeratosis is seen in all except or something like this. So PEASE-2 is the mnemonic which you remember for parakeratosis. Similarly, there is a term which is asked which is called as dyskeratosis. Dyskeratosis is nothing but abnormal keratinization. Now the normal keratinization process, I have told you, starts in stratum granulosum. When this keratinization becomes abnormal, it is referred to as dyskeratosis. Can you tell me some conditions where you see dyskeratosis? So you see it in certain benign conditions and certain malignant conditions. So what are these conditions? Quickly, let's make it more interactive. So quickly keep answering and keep asking questions, because otherwise it gets boring for us. Good job, Dr. Lakshay. Yes. So in benign conditions, I have diarrheas. So D for dyskeratosis, D for diarrheas, and Haley-Haley, because both of them are dyskeratotic inherited acantholytic disorders. So diarrheas and Haley-Haley are benign conditions. Malignant condition we will remember with the mnemonic BSP, BCC, SCC and Paget's, right? So dyskeratosis is seen in these conditions. There are a lot of other pathological changes, but here we are covering just the important ones. Now, these lines are sometimes asked, what are the lines which are, so what are these lines? Give me the name for these lines. Just an image is given and you have to identify based on the image that what are these lines. Good. Very good. You're right, Dr. Gaurav. Good job. So not Langerhans lines. Langerhans are cells. These are Langer's lines. These are Langer's lines and these are Blaschko's lines. Just looking at the picture, how will you identify? Remember, Blaschko's lines are all curvy. So, you see all curvy spiral pattern here. So, these are Blaschko's lines, whereas Langer's lines are straight. So, if you see straight lines, say Langer's line. If they give you curvy lines, you think of Blaschko's lines. What is the difference? Blaschko's lines are lines of embryonic development. It has C, so it is constant, and it shows a strict midline demarcation. Langer's line has anger. Anger is never constant, so these are not constant. They follow orientation of collagen and muscle bundles and they help us in giving incisions. Blaschko's lines, some conditions which can present in Blaschko's lines are Ven, xeroderma pigmentosa and what else? Incontinentia pigmenti. So, all these conditions can present in Blaschko's line. Ven and incontinentia pigmenti are commonly asked. So, incontinentia pigmenti, whenever they give you image, they will give you image of Blaschko's lines. Good, very good. So, moving on, what is this condition that I have shown? Give me the diagnosis here. Though partly diagnosis has been given, but still let me see. So, you are going to give INI-CET. I need better response than just impetigo. What kind of impetigo? Impetigo is of two types. We know bullous impetigo, non-bullous impetigo. What is this? Yes, you see crust, and these are golden colored crust, or sorry, not golden colored but honey colored crust. So, honey colored crust is what you see. So, this is non-bullous impetigo or impetigo contagiosum. In bullous impetigo, you would be given bulla and that's hardly given. So, that is why I have put an image of non-bullous impetigo or impetigo contagiosum, which presents with honey colored crust. They can also give you a gram stain. Gram stain is showing gram positively bacilli which are arranged in clusters. So, gram positive cocci which are arranged in clusters is what you see in this. Why? Because it is caused by strep and staph. So, the organism causing this is strep and staph. For bullous impetigo, we have staph as the main causative organism, and for non-bullous impetigo, strep is the main organism, right? So, if they give you this, it is mostly streptococcus and staph present similarly on gram stain. So, they can even ask you treatment. So, treatment for this is just giving topical antibiotics. Topical antibiotics. So, this helps. Then second thing that helps is this gram stain. So, if I am giving you a gram stain image, think of staph strep infection, think of non-bullous impetigo. Now, in bullous impetigo, what is the target? This has been asked, so that is why I have put in here. So, in bullous impetigo, you see bulla being formed. Why are bulla being formed? What is being targeted that leads to bulla formation? Yes, you all are right. It can be mupirocin, it can be fusidic acid. You know about topical antibiotics. So, quickly, target in bullous impetigo is anyone? So, this is desmoglein 1. So, bullous impetigo, the target is desmoglein 1, which is same as the target that you see in staphylococcal scalded skin syndrome. You see it in pemphigus foliaceus. So, desmoglein 1 is a target in all of these conditions, right? Got it? Now, this is again a very common image which is given to you. I have written everything, so I am not going to ask you. What is this? This is staphylococcal scalded skin syndrome or SSSS. There is usually a history of focus of infection somewhere, then it leads to exfoliative dermatosis, would usually be seen in newborn child, and the child would be admitted in ICU. Can start with ear pain, can start with something in the, can start with a folliculitis, any focus of infection from which which tells us that there has been a staph colonization. This staph releases a toxin called as exfoliative toxin or ET toxin. This toxin targets my desmoglein 1, leading to split and leading to this exfoliation of skin. This is called as scalded skin syndrome or staphylococcal scalded skin syndrome. So, there is staphylococcal, there is scalding which happens because of release of exfoliative toxin or ET toxin, which is targeting desmoglein 1. If you do a Nikolsky here, it will come out to be positive, and this is an indication for giving not topical but systemic antibiotics. So, impetigo you treat with topical antibiotics, this you treat with systemic antibiotics. Yes, this is true Nikolsky sign because here there is a desmoglein 1 target which is there, right. So, this is true Nikolsky. True Nikolsky is also seen in, as you all know, Pemphigus group of disorders, right. Got it? Now, what is this? A patient is presenting with pain, tenderness, constitutional symptoms which are present on upper limb. Sorry, I'm really sorry about that. Yeah. So, which is present, they can give you limb, they can give you ear, but mostly upper and lower limb is given. Now, here, yes, you are right. You have to look at one important thing to identify what is it. If there is well demarcation, if the lesions are well demarcated, you would say it as erysipelas. However, if the lesions are not demarcated and are deeper, you call it as cellulitis. Right? Yes. So, only thing that you need to look into the question is whether the lesions are well demarcated or not demarcated. Well demarcated, think of erysipelas. Not demarcated, think of cellulitis, because cellulitis is deeper. If it is cellulitis, they may not ask you what it is. In fact, they may ask you what is the causative organism. So, erysipelas is caused by group A beta hemolytic streptococci, and cellulitis is more commonly caused by staph and then strep. So, there was once a question where they had given you this in the image, and in the question they had said that it was well demarcated and they have asked you the causative organism. So, you should know it is group A beta hemolytic strep. They have also given group B beta hemolytic strep. So, no, it is group A beta hemolytic strep. So, you should know about this organism which causes erysipelas. Again, here you need oral antibiotics because here again the infection is deeper. Okay. So, this is another important bacterial infection that you know. Next, I am sure you all know about this. This is erythrasma. Erythrasma is again a bacterial infection caused by Corynebacterium, and the causative organism for erythrasma is Corynebacterium minutissimum. What are the other infections which are caused by Corynebacterium? It is pitted keratolysis and trichomycosis axillaris. So, trichomycosis axillaris, pitted and erythrasma are three Corynebacterial infection. This has again been asked, and that's why I'm telling you. Erythrasma is most commonly asked, caused by minutissimum, usually seen in interweb space, axilla, groin or inframammary area, and presents as well demarcated, non-itchy, mildly scaly lesions, right? Now, here typically they give you a Woods lamp image which you all are telling me, right? Yes, there is coral red fluorescence that you see, and this coral red fluorescence is because of production of coproporphyrin 3. So, this is very helpful because sometimes when you have these lesions in the underarms, you can mistake it with tinea, but this is not tinea because you see this coral red fluorescence, right? So, Corynebacterium. What is the treatment for erythrasma? Again, you give topical antibiotics, preferably you give topical clindamycin. Am I muted? Is there an issue with volume, people? Students, you are not able to hear me? Uh-oh. Where has the sound gone? All okay? So someone is saying all okay. What's this? Good. So great. So you are able to hear me. Great. So topical clindamycin is the treatment of choice for erythrasma, right? So erythrasma, usually they'll ask you the causative organism or the kind of fluorescence and why is that fluorescence caused. So it is coproporphyrin 3. Clear? Now, another bacterial infection that is commonly asked is this. What is this? Anybody? Good. So you are right. I have given you enough hints here. This is anthrax. Now, how do I identify anthrax? This is not enough. So you have to give me some hints. So in the question, there will be some hint like a livestock handler is presenting on the periphery, on the extremities with a lesion like this. They can ask you what is it. They can ask you what is the lesion called. So lesion is called malignant pustule, or they can ask you the bacilli which causes it. It is Bacillus anthracis. So it is a zoonotic infection seen in livestock handlers. Since it is zoonotic, it would be seen usually on the periphery area, and you see a crusted lesions with edema and erythema of the surrounding skin. This lesion is called as malignant pustule, but please remember this is not malignant and there is no pustule which is seen here. So it's a misnomer, but the lesion is still called as malignant pustule. So anthrax, you should know this. Okay. Now, coming to few of the fungal infections which are asked. So I've given you a hint. Yes, we are talking about Tinea capitis here. So what is this kind of Tinea capitis? What is this? This image that I've ticked. What is this? Which form of Tinea capitis is this? Why is it favus? I do not see any cup-shaped crust here. This is not favus. I'll give you a brief history. A 12-year-old boy presents with a patchy alopecia with greyish scales on top. So there is patchy alopecia, there are grey scales on top. Yes, good. So this is an ectothrix infection. What is this called as? So this is not endothrix. Okay. So students, don't get confused. If you are seeing grey scales on the patch, what are these grey scales? These grey scales are fungal colonies. So fungal colonies, if you are seeing, that means the fungus is outside the hair shaft, and so this is ectothrix infection. And this is called as grey patch Tinea capitis. Very easy to remember. Don't memorize. Grey patch Tinea capitis. What is this grey scale? Grey scales are fungal colonies. If you are able to see fungal colonies, they are outside the hair shaft. If they are outside the hair shaft, that means it's an ectothrix infection. And since you have fungal colonies outside, if you do a Wood's lamp fluorescence will be positive here, right? And you would see what? What kind of fluorescence is seen? You see a bluish green fluorescence here. Bluish green fluorescence is seen. So this is grey patch Tinea capitis presenting with patchy alopecia with grey scales. It is ectothrix. Clear? Yes. Now, next, coming to the next picture which I have here. What is this? What is the next image showing? Again, I have a 12-year-old boy who is presenting with patchy alopecia with, I can see some black dots on the surface. So this is black dot Tinea capitis. There is no scaling. So you are all right. This is endothrix, because here what is happening, the fungus is inside the hair shaft causing swollen hair shafts, and these swollen hair shafts appear as black dot. So black dot Tinea capitis or endothrix kind of infection is what this is representing. It will also present with patchy alopecia. Now, since the fungus is inside, if you do a Wood's lamp fluorescence, it would be negative here. Okay. Now, causative organism for this is usually Trichophyton. Trichophyton tonsurans, Violatium and Sudoni. But Trichophyton tonsurans is important because this is the most common species these days which causes fungal infection. Earlier it was M. canis. M. canis causes grey patch or ectothrix infection. But now this is less common. Trichophyton tonsurans has become most common species of Tinea capitis. Clear? Yes. So, black dot, grey patch. Now coming to the other forms. What is this? Boggy swelling is there, pain is there, lymphadenopathy is there, but KOH is negative, caused by verrucosum mentagrophytes, big name. This is Kerion. So, anywhere in dermatology you hear about boggy swelling, you see something like this where there is a boggy swelling studded with pustules, broken hair shafts. This is Kerion. It is the inflammatory type of Tinea capitis caused by T. verrucosum T. mentagrophytes. This is very inflammatory, can heal with scarring. So much inflammation that the inflammation kills the fungus, and KOH is usually, KOH and culture are negative. Right. So, if you see a boggy swelling, think of Kerion. Again, Wood's lamp fluorescence will not be seen in this kind of Tinea capitis. Now, some people were confusing that with favus. This is favus. You see these cup-shaped crusts. These are called as scutula. Cup-shaped crusts are called as scutula. It is also an inflammatory type of Tinea capitis. Yes. What is it caused by? What is favus caused by? Scutula, favus. Yes. What is it caused by? This scutula is also fungal debris which are collected, and that's why if you do a Wood's lamp fluorescence, it would again be positive here. Yes, it is caused by T. schonleni. Right? So, favus is caused by T. schonleni. It leads to cup-shaped crust called as scutula, and it shows Wood's lamp fluorescence to be positive. Favus and Kerion are inflammatory type of Tinea capitis, and grey patch and black dot are non-inflammatory type of Tinea capitis. Clear? Now, okay, what is this? I have a 30-year-old male who presented with an itchy rash on thighs. He applied some OTC creams, thighs. He applied some OTC creams or over-the-counter medications, improved but relapsed. Wonderful. Very good. So, you are all right. So, this is Tinea incognito or hidden tinea because of application of OTC creams which usually contain steroids. So, the picture of tinea changes. You do not see a classical annular rash as is seen in tinea. You see this vague kind of pigmentation, pustules which are there. So, this is itchy rash on thighs, improves and relapses because the patient has been applying OTC cream. So, you all know about it. So, this is tinea incognito. You should be able to identify this. Now, very important question. I am bored of teaching this, but the examiners are not bored of asking this. So, we have to know this. So, this subcutaneous mycosis is very important. Almost in every exam, I see a question on subcutaneous fungal infection. So, remember subcutaneous mycosis is mainly three that you need to know: sporotrichosis, mycetoma, and chromoblastomycosis. One, you should know that these are subcutaneous mycosis. This subcutaneous mycosis means that the fungus has gone up to the subcutaneous tissue. So, these are the mycosis which are usually caused by pricks, thorn prick, prick by a rose flower or something like this. So, usually pricks and usually seen in farmers or people who work in field. So, there was once a question which was asked, all of these are caused by thorn pricks except. So, you should know that these three are subcutaneous mycosis which are usually you have to reach the subcutaneous tissue. So, there has to be some prick which has to be there which will land the fungus in the subcutaneous tissue. Clear? Right. Now, So this one is particularly, you are right, this is Rose Gardner's disease or sporotrichosis. An easy way to identify is you are seeing linear distribution of nodules or papules. So whenever there is linear distribution of nodules and papules, think of sporotrichosis. This linear distribution is because there is lymphatic spread, and so the infection spreads around the lymphatic, so it's usually linear in distribution. It can be seen in farmer, it can be seen in rose gardeners. The causative organism is Sporothrix kenkai, another very important question. Right? So linear distribution of nodules and papules in a farmer, in a rose gardener, think of sporotrichosis, right? So now, what is this that I am showing you? Good. What is this? This is also seen. Now these are usually, this was also asked, so this is dimorphic fungus. So they can give you even an image of yeast with buds being formed. Now what is this? So if you do a histopathology, so this is a histopath image. So if you do a histopathology, you see asteroid bodies here. So what is Splendor-Hopley reaction? Somebody told me Splendor-Hopley reaction or Splendor-Hopley phenomena. So Splendor-Hopley phenomena is, suppose if there is a fungus which is there, the immune system starts to target this fungus, and there is this fungus is entrapped by the immune cells in a star-shaped body, which is called as asteroid body. So asteroid body is classically seen in sporotrichosis, can also be seen in other fungal infections. It is not exclusive but quite commonly seen here. Yes, it is seen in actinomycosis as well. You're right. Right? So asteroid bodies, linear distribution of lesions, and if you do a PAS stain, what will you see? You would see cigar-shaped bodies. Cigar-shaped bodies are seen. So you're right, these asteroid bodies are also seen with actinomyces. How do you treat? So treatment of sporotrichosis is also asked. You can give itraconazole, or you can give potassium iodide also. So itraconazole is the treatment of choice for sporotrichosis. So this is commonly asked, so I've told you all about it, right? Now what is this? This is the second, subcutaneous mycosis, which is again very commonly asked. Since they got bored of sporotrichosis, last 2 times they've been giving you this. So this is mycetoma. Now, important thing that you should be knowing in mycetoma is that mycetoma can be caused by bacteria or fungus both. So it's not just fungus which causes mycetoma, it can be bacterial also, in which case I call it actinomycotic mycetoma and fungus is called as eumycotic mycetoma. Right? Now here the common species are nocardia. Here the common species eumycotic eumycetoma. Madurella mycetomatis. Good job, you're all well read. Now, how do you know whether it is bacterial or fungus? The clinical picture almost remains the same. That is, there is induration, there are grains, there are sinuses. So, you have a farmer who presents usually with a lesion on the foot which is painless, and this lesion is swollen, there are grains, there are sinuses which are there from which the grains are being released. But how do I identify whether it is bacterial or fungus? So very important is color of the grains. So if the color of the grains is black, think of fungus as the cause. Whereas if the grain is red, yellow, then think of it as actinomycetoma. Yes, very good. So if you have black granules or black grains written in the question, then the answer is eumycetoma or eumycotic mycetoma, and then it is caused by Madhurella mycetomatis. If, however, the grains are red yellow, you think of actinomycotic mycetoma, and nocardia may be the reason. Then deformities are more common with fungal infections, because fungal infections are usually asymptomatic, so they are more progressive, they are associated with more deformities, whereas actinomycotic mycetoma, since it is bacterial, the patient presents early, and so the chances of deformities are low. Clear? So mycetoma, you should be able to identify mycetoma, and you should be able to identify whether it is actino or eumycetoma, right? Yes, you're right, Dr. Gaurav. So since it's very, very invasive, the fungal one, it can involve the bones, and that's why you have deformities here. Clear now? Good. Now coming to viral infections, HPV is something which is asked. So human papilloma virus or HPV has numerous strains, more than 200 strains. They ask you this strains sadly. So we'll remember some of them. So the mnemonic you all know is DSP, come eat a burger. DSP, come eat a burger. So D is deep plantar, superficial plantar, P is plain wart. Then come is common, eat is EDV, A is anogenital, and B is butcher's wart. So 1, 2, 3, 4, 5, 6, 7 you write down, and these are the different kinds of infections caused by these subtypes of HPV. So deep plantar 1, superficial plantar 2, plain warts is HPV 3 and 10. Now if you want to remember the most important ones, so these are the most important ones which are asked. So plain warts or verruca plana is 3 and 10. Common warts or verruca vulgaris is 4, 2 and 27. Anogenital warts can be low risk or high risk. So low risk is caused by 6 and 11, and high risk is caused by 16, 18, 31, 33, 45. Right? So this way you can remember, but just remember in anogenital low risk and high risk. Now high risk HPV type is something which is associated with underlying carcinoma. These HPV strains are more likely to cause underlying carcinoma. Clear? Okay, now few images. So what is this? So this is when you see hyperkeratotic papule which have very rough surface, something like this. So these are verruca vulgaris. Whereas when the lesions are plain topped like this is plana, verruca plana or plain warts. Now plain warts are more commonly seen on face, and they are more common in immunocompromised individuals. So patients on chemotherapy, patients who have HIV, more commonly you see in them. So plain warts more commonly seen on face, more common in immunocompromised individuals. And what is the strain? 4 to 27, and here 3 and 10. Clear? So this is what you have to identify. Remember, all these warts are painless. They are all painless, and so they are persisting and persisting. Yes, dear, these are all HPV associated. We are talking about HPV strains only, or human papilloma virus strains only. Any confusion? Right? Great. Now, what is this? I am telling you that I am seeing target lesions. When target lesions means there are 3 zones to it, and I am telling you that the most common cause is infection, and in that also it's SV is the commonest organism. So what is it called as? Target lesions, I am telling you, what is this disease called as? Target lesion is the clinical feature. Erythema multiforme, you are right. So this is also us. So erythema multiforme is something, it's a reaction pattern which can be because of infections, or it can also be drugs. So more commonly it is the infections which are the common cause, and out of infections it is HSV. So you may be given a history of herpes genitalis, herpes gingivostomatitis, that the patient has recurrent erosions or genital erosions which are painful, and now is presenting with these target lesions which are usually seen on periphery. So think of erythema multiforme, and this
is most commonly caused by infections. Clear? What is the issue with the voice? I'm so sorry. Are most of you facing voice issues? So is it something from our end or your end? So it depends on if everyone is facing voice issues, because some people are saying that there are no voice issues, some people are saying which drugs are associated with it. So there can be numerous drugs which can cause it. It can be painkillers, it can be antibiotics which can cause it. Okay, so I'll just get the voice issue checked. Let me see what is the issue. So I'll keep talking and you tell me if it gets okay. Okay, now in viral infection, this is another very important question. I have painful vesicles which are present in dermatomal distribution. Now here I am telling you dermatomal distribution, but in the question you may just be given this image, and this image is typically in a dermatomal distribution. So dermatome is an area of skin which is supplied by one particular nerve. So remember, in skin there is a midline demarcation. So a dermatome on one side is supplied by different nerve and on the other side it is supplied by different nerve. But if you are given painful vesicles in dermatomal distribution, you have to think of zoster or shingles, as you rightly pointed out. So zoster or shingles, which is caused by varicella zoster virus. Varicella zoster virus. Here varicella is the chickenpox thing and zoster is the herpes zoster thing. So they are both caused by same virus. Chickenpox in childhood, this virus gets latent in dorsal root ganglion and later in life leads to herpes zoster. So chickenpox, when you have, the virus gets latent in dorsal ganglion and later in life leads to herpes zoster. So a question which is asked is, they can tell you to identify this, they can ask you the causative organism, they can ask you the treatment, which is acyclovir 800 milligram 5 times a day. It is not reinfection. Please understand students, this is not reinfection. It is reactivation of virus which is happening. Don't mark this as reinfection. So reactivation of virus happens. The virus is latent in a nerve or in the dorsal root ganglion, and from there the virus gets reactivated, and that is why the question that is asked is, since it is reactivation of virus, infectivity is very low. It's not zero, but it is very low. While chickenpox is highly infectious, herpes zoster, the infectivity is very low. It can transmit infection in very young age children, people who are non-vaccinated, people who are immunocompromised. So in those cases we have to take care of the chances of spread of infection. Otherwise the infectivity is very low. Yes. So the dermatomes which are most commonly involved as thoracic dermatome is the most commonly involved, followed by cervical dermatome. Thank you for that. Right. So this is herpes zoster. Herpes zoster is also associated with few signs which I'll quickly tell you here only. So there can be something called as Hutchinson sign. So Hutchinson sign, if there. So what is Hutchinson sign? If you see vesicles on the tip of the nose, there are high chances that the patient will develop herpes zoster ophthalmicus or eye involvement, because lesions on the tip of the nose tell me that there is involvement of nasociliary nerve, which is a branch of ophthalmic division of trigeminal nerve. So if this is involved, that means there are high chances of herpes zoster ophthalmicus, and this is called as Hutchinson sign. Where else have you studied about Hutchinson sign? Anybody? Hutchinson's, where have we studied this word Hutchinson's? Not sign particularly, but Hutchinson's is something we have studied. Very good. What kind of syphilis? What kind of syphilis? And what is there in syphilis in Hutchinson? No, not tertiary syphilis. Yes, congenital syphilis. Late congenital syphilis can present with Hutchinson's teeth, and there can be Hutchinson's triad, right? So, Hutchinson's triad, in which you can have eighth nerve involvement, there can be interstitial keratitis, and the patient has Hutchinson's teeth. So, you have studied about Hutchinson's sign in herpes zoster and Hutchinson's teeth in late congenital syphilis. Yes, there is sensorineural hearing loss, there is teeth, and there is interstitial keratitis. Good. What is this? I have written, so I have no point asking. So, now they ask you these two disorders which we see very commonly in HIV positive patients are asked in the exam, where on the lateral border of the tongue you see this white corrugated surface, or these projections, white projections, verrucous projections on the lateral border of the tongue. This is referred to as oral hairy leukoplakia. Oral, lateral border of the tongue, hairy because they look like hair, leukoplakia because they are white. So, oral hairy leukoplakia is commonly seen in HIV positive patients, and it is an infection which is caused by Epstein-Barr virus. What else does EBV causes? What other infection does EBV cause? Because they have this habit, they give you this and they can ask you that the virus which is causing this can cause what? So, anybody? Yes, Kissing's disease, which is also called as infectious mononucleosis. Amazing, good job. So, infectious mononucleosis is caused by EBV, and this also causes oral hairy leukoplakia. Yes, this is pre-malignant and the patient needs to go biopsy, undergo a biopsy, right. Then what is this? This is again seen in HIV positive patients. It is caused by HHV8 or human herpes virus 8, and this is usually called as vascular tumor of endothelial cells. So, Kaposi sarcoma, you are all right. This is a question again which is commonly asked. They give you this image where you see deep red to bluish nodules which can be present on the body. They can also be present in the mucosa. So, deep reddish to bluish nodules which are nothing but vascular tumor of endothelial cells. This is caused by HHV8, again seen in HIV positive patients, and this is Kaposi sarcoma. Clear? Good job. Okay, what is this? I have given an image of, so this can be an 8-year-old boy presenting with asymptomatic plaque on his buttock as shown in the image. What test will you do to confirm your diagnosis? The question, obviously all of you have given me the answer that this is lupus vulgaris. What is the next best test that you would do to confirm your diagnosis? Next best test. So, apple jelly nodules are seen in dioscopy, but apple jelly on dioscopy can be seen in all granulomatous disorders, right? So, what do you do here? So, dioscopy is done, you're right, but that's not one of the best tests. Dioscopy will say that there are apple jelly nodules which can be seen in various granulomatous disorders, right? So, sorry. Yes, so when you see a patient of lupus vulgaris, you do a skin biopsy which shows you granulomas, and that is very, very diagnostic. But if there is still a confusion, you can do a PCR. So, skin biopsy and PCR both help in identifying it as lupus vulgaris, right. So, my first investigation would be skin biopsy, in which I see granulomas, but if skin biopsy is not there in the option, you can even mark PCR. PCR is further confirmatory but not done commonly because it is not easily available and is costlier, right. apple jelly nodules are seen on dioscopy. So, this is lupus vulgaris. Lupus vulgaris can spread through all kinds of routes, through hematogenous routes, inoculation route, different routes it can spread to, and it is usually seen in individuals who have good immunity. That is why such well defined granulomas are formed. Okay. So, this is lupus vulgaris. Now, what is this in similar terms? So, I have a 9-year-old female who presents with a painless lump in the cervical area, and when you examine you see this. So, there is a lump here and you see these draining sinuses. Yes. So, draining sinuses. So, this is scrophulloderma. Scrophulloderma spreads by So, scrophulloderma is again a form of skin TB which spreads by contiguous spread. What do you mean by contiguous spread? That there is an underlying focus of TB and that is giving away in skin. So, underlying focus of TB can be lymph node, can be a bone, can be lacrimal glands. Most likely it is lymph node, and in lymph node also cervical lymph node is the commonest. So, there is an underlying lymph node which breaks out into the skin as skin TB, and this is called as scrophulloderma, right. So, scrophulloderma, yes. So, it is coming from the deeper tissue to the skin. Absolutely right, right. So, you should be able to identify scrophulloderma as well. The third form of cutaneous TB which is very commonly asked is tuberculosis. Now, this is different. This is not just cutaneous TB, it is a hypersensitivity reaction to TB bacilli which is present somewhere in the body, not in the skin. So, there is a TB foci somewhere, and from there some bacillary antigens are being released, to which my body mounts a hypersensitivity reaction which presents in skin as tuberculosis. So, this is a type 4 hypersensitivity reaction, and there has to be a primary focus elsewhere. Since the body is mounting an immune response, the MON2s has to be positive. If you do a histopathology, the histology would be tuberculoid, but culture will be negative because it is a hypersensitivity reaction. The bacilli is not actually sitting on the skin. But if you treat the bacilli, the hypersensitivity reaction also treats. So, there is response to ATT, right. So, tuberculosis, the patient has good cell mediated immunity. It is a type 4 hypersensitivity reaction, and this criteria is very commonly asked. There are two kinds of tuberculosis which are commonly you should be knowing about. So, one is lichen scrofullosorum. Lichen scrofullosorum is usually seen in children. Here you see very tiny micropapular lesions which are present in grouped arrangement around the follicles on the trunk. So, you see these trunk may grouped perifollicular lesions. In children, no scarring is seen. These are lichen scrofullosorum versus papulonecrotic tuberculid. Is usually seen in adults. This is usually seen in extremities and will present with necrotic papules which can show scarring, right. So, on the extremities, adults can present with necrotic papules which results in scarring. So, papulonecrotic tuberculate. Got it? So, these are two tuberculosis that you should be commonly knowing about. We will move on to leprosy now. So, are you guys okay with the speed? Are you with me? Are you able to understand? I am sorry I am speaking more and asking less because there is limited time and I want to cover the maximum topics, but I hope you are able to revise with me and understand with me. Any questions on the topics which we have discussed already? Great. Good job. Great. Thank you for the input. So, we will move on to leprosy. In leprosy, you should be able to identify the various spectrums of leprosy. You should be able to differentiate between type 1 and type 2 reaction, and you should know about the treatment of leprosy. I mean, this is very, very basic. They may ask you here and there, but these are the topics which we can discuss last moment and revise last moment. So, I am doing that. So, I'll ask you a question. In the Ridley-Joplin classification, there are two kinds of leprosy which are not included. So, that tells you that the classification which is followed by leprosy is Ridley-Joplin classification. But Ridley-Joplin classified leprosy into different spectrum, but he did not include two types of leprosy. What are they? Tell me, anybody? Yes, so one is indeterminate and the second is what is Hansen? Hansen means leprosy. So, Hansen is a broad term. Hansen means leprosy, nothing else. So, indeterminate Hansen or indeterminate leprosy and pure neuritic leprosy. So, these are the two forms of leprosy which were not included by Ridley-Joplin, and these two are endemic to India. So, we should be knowing about that. So, first talking about indeterminate leprosy, it is a kind of leprosy in which my immune system is still not determined whether to go towards the TT Hansen, BT, BL, LL or whatever. So, it is still confused. Lot of patients heal after the indeterminate stage. So, the patient goes into the indeterminate stage and there is spontaneous healing that happens. Only few patients from indeterminate Hansen will go to various spectrums, right. So, what is indeterminate leprosy? Here you see usually a vague single hypopigmented to erythematous lesion in which there is no loss of sensation, no infiltration, no nerve 2 patch. You do an AFB, there is no AFB. Only if you do a histopathology, you see some perineural infiltrate, and this is called as indeterminate leprosy. In this, you just wait and watch and see whether it moves to determinate Hansen. Now, a close DED which is given along with this is pityriasis alba, which is a type of eczema. So, in pityriasis alba, again you see it on the face, you see it in children, but usually the lesions are multiple. There is some scaling on the lesion, and if you do a histopathology, there is spongiosis that is seen, no perineural infiltrate. So, if you have a face of a child with multiple lesions, scaly hypopigmented lesions, usually seen in atopics, and you do a biopsy, you see spongiosis, so that is pityriasis alba, right. Okay. Now, coming to determinate forms of leprosy, which are the known forms of leprosy, right. Now, here you have BT, TT, BT, BB, BL and LL, right. So, this is the spectrum which was defined by Ridley-Joplin. Out of this, BT is most commonly seen spectrum, and that is most commonly asked, and that is why I have put in here. So, this is the most common form of determinate Hansen. Patient will present with 10 to 20 lesions with 10 to 20 centimeter size with loss of sensation which will not be complete. In TT, there will be 100% loss of sensation, whereas here there will be loss of sensation, but it will not be complete. Absolutely right. What do you see here? You see these satellite lesions, easy to understand. Now, the lepra bacilli is trying to spread. So, you see satellite lesions and you see pseudopodia. So, pseudopodia and satellite lesions are a feature of BT Hansen. Right. Now, what happens in BL Hansen? In BL Hansen, this is towards the lepromatous pole. So, you have numerous lesions which are ill defined, which have tendency to be symmetric, and there you see glove and stocking anesthesia. So, when we move from tuberculoid pole to lepromatous pole, our lesions become smaller, our lesions become more ill defined, they tend to be symmetrical all over the body, and the anesthesia in tuberculoid pole is on the lesion, whereas anesthesia in lepromatous pole is towards the glove and stocking anesthesia or towards the periphery. Are you clear about that? So BL Hansen will have more of glove and stocking anesthesia. And the typical appearance that you see here is called as inverted saucer appearance. So inverted saucer appearance is something like this. The lesion looks something like this because the bacilla is trying to spread. There is infiltration in the center. So inverted saucer appearance. Saucer right way up, which is this, is seen with TT Hansen. So saucer is usually the right way up is seen with TT Hansen. BL Hansen, you see inverted saucer appearance. What happens in BB Hansen? BB is the most unstable form. From BT, the patient is going to BB and then BL. So BB is a very, very unstable form. Patient does not stay there. Now here again, the body is confused. There were tuberculoid lesions, so larger lesions. Now these larger lesions are spreading and going towards the BL Hansen. So you see geographic or map-like configuration here. You see geographic or map-like configurations in BB Hansen. Nerve thickening, yes. So when we talk about tuberculoid pole, you usually see a peripheral nerve being thickened in the vicinity. Whereas when you move towards lepromatous pole, there is generalized involvement of peripheral nerves, and that is why you see glove and stocking anesthesia. Right? So map-like geographic configurations is seen in BB Hansen. Also punched out appearance is commonly seen in BB Hansen. So in BT, we had satellite lesions, we had pseudopodia. In BL, we had inverted saucer appearance. In BB, we have map-like or geographic configurations or punched out configurations. Clear? So this is something which are asked in the spectrum. Now, they ask you very, very commonly about type 1 and type 2 reactions in leprosy. So I'll quickly discuss that. Type 1 reaction is seen in patients who are in upper spectrum. That is usually seen in BT Hansen. It is a type 4 hypersensitivity reaction, usually seen after you start MDT. Now what happens in these patients? They are usually patients with good immune system. So when you start them on MDT, the bacilla is killed. My body generates a hypersensitivity reaction or type 4 hypersensitivity reaction against this bacillary antigen, which leads to existing lesions becoming more red, swollen and painful. Right? So type 1 reaction are also called as, yes, you are right, they are called as reversal reactions, and here it is seen in upper spectrum, type 4 hypersensitivity after starting MDT, existing lesions being effective, and there is nerve involvement leading to even abscess formation. Right? Now coming to type 2 reactions. Type 2 reactions are seen in lower spectrum, lepromatous pole, so usually seen in BL. Type 2 is type 3 hypersensitivity reaction. That means there is antigen antibody complexes being formed. In leprosy, I have told you antibodies are not protective. So in lepromatous pole, the immune system is low. So what body generates is antibodies. So there are antigen antibody complexes which are formed. Now this usually happens whenever there is some pregnancy, infection or immunocompromised states in patients with leprosy. Because of that, their immune system further lowers, further antigen antibody complexes are formed, which gets deposited in the skin and thus leads to new crops of lesions being formed. So new crops of tender evanescent papules and nodules with evening temperature rise is seen along with constitutional and systemic symptoms. Right? So we have type 1 and we have type 2 reaction. Got it? Any confusion in type 1 and type 2 reaction? Now the good thing is, even if you get confused and they ask you the treatment for both of them is continue MDT or give MDT if the patient is not taking, and give oral steroids to the patient. Continue MDT and give oral steroids to the patient. So with both type 1 and type 2 reaction, oral steroids are the drug of choice and you need to continue MDT. Where do you use thalidomide? You can even use thalidomide in type 2 reaction, but yeah, okay. So that is also one way to remember. 4 plus 1 is 5. 5 or its type 2 is type 3 and 1 is 4. So 1 plus 4 is 5 and 2 plus 3 is 5. So you can remember like that also. So thank you for that reminder for that mnemonic. So to remember that what type of reaction, 1 is 4, 2 is 3, 1 plus 4 is 5, 2 plus 3 is 5. Now I was talking about the role of thalidomide. So thalidomide is a second line drug in type 2 reaction and is usually given when the patient is either not responding to steroids, can't be given steroids because the patient may be highly diabetic, or there are some other contraindications for not giving steroids. So in that case you can use thalidomide. Why is thalidomide not used commonly? Because thalidomide is teratogenic. Remember that thalidomide is teratogenic and should not be given in females who want to conceive. Clear? Yes, Lucio phenomena is also a type of reaction that you see in leprosy patients, but that's a topic to be covered with the main lecture, not something which I will be discussing in the last resort revision. Okay, yes, thalidomide causes phocomelia. It is a teratogenic drug. Now, another important topic in leprosy which is asked is MBMDT, or what do you give for treatment? MBMDT is multi-drug therapy. Now, why do we give multi-drug therapy? Multi-drug therapy is given to prevent resistance. To prevent resistance, you give multi-drug therapy. Okay, so multi-drug means multiple drugs are given. So 3 drugs are given: dapsone, rifampicin and clofazimine, and you should be knowing their doses. So what is the dose of, so easy way to remember is the dosing for leprosy treatment is monthly and daily, right? Now D for daily, D for dapsone. So dapsone is the drug which is given daily. Rifampicin is given monthly. So rifampicin has M, rifampicin is given monthly. Clofazimine is given daily and monthly both. Now, rifampicin is given 600 milligram once a month, whereas clofazimine is given half of that dose, which is 300 milligram once a month. Dapsone is given 100 milligram daily, clofazimine is given half of that dose, 50 milligram daily. So it's easy to remember, rifampicin is monthly 600, clofazimine half of that 300 milligram monthly. D for dapsone, D for daily. Dapsone is 100 milligram daily, half of that is clofazimine, 50 milligram daily. Right? Now, earlier there were different blister packs for multi and paucibacillary leprosy. Now we give common MBMDT for all, just that if it is a multibacillary kind of leprosy, we give it for 12 months and we give it for 6 months in paucibacillary leprosy. Everything is given under supervision, but especially the monthly dose is given under supervision. Now, if I have a child of 10 to 14 years old, how the dosing changes? From 100 milligram, it becomes 50 milligram. From 600 milligram, it becomes 450 milligram. Here, 300 milligram becomes 150 milligram, and this 50 milligram becomes 50 milligram alternate days. So almost the dose is halved except for rifampicin, which from 600 becomes 450 milligram, and usually this is what is asked, right? So all of the doses are halved, but for rifampicin, which from 600 goes down to 450 milligram. Clear? Now, this is how the blister packs look like. So, this is for adult and this is for child. So, you should be able to identify this. So, monthly doses are supervised, rest is given to the patient to take at home. Okay. Now, coming to the next topic, which is genital ulcer disease, we know that we should be well versed with 5 genital ulcers, which are these, and I'll quickly discuss the important features of those. Right, I'll show you the images also, but first we'll discuss the important features. This would be a very handy table for you to revise last moment. I've tried to put in all the important features which can help you with the genital ulcer disease here. So, first we will talk about syphilis. Now, syphilis causes single lesion which is painless, which shows induration. So, single painless indurated lesion is nothing but syphilis, right? Single painless indurated lesion is syphilis. The edges are sharply demarcated, the base is clean, and the lymph nodes are shorty. I am marking the important points. The causative agent is Treponema pallidum. The test that you do to identify the bacilli is dark ground microscopy, and treatment that you give is penicillin. So, this covers the important features. Single painless indurated lesion with well defined edges, clean base, shorty lymph nodes, again painless, is all syphilis, right. Now, I will not talk about herpes. Herpes and chancroid are both multiple, they are both painful, and they both have no induration. So, multiple painful lesions with no induration can be herpes or can be chancroid. So, it is common, all these features. But what is the difference here? Herpes usually does not present with ulcers, but presents with polycyclic erosions and coalescing vesicles. So, with herpes you see vesicles and erosions which are coalescing and polycyclic in nature, whereas with chancroid you see an ulcer which has undermined edges with dirty grey base. So, it is not a clean base like syphilis, the edges are not well demarcated, it is an undermined, this is an undermined ragged edge. So, this is very, very important for chancroid. Painful multiple lesions with undermined ragged edges with dirty grey base is chancroid, whereas painful multiple lesions, no induration but vesicles and polycyclic erosions, and there can be history of recurrence here, is herpes, right. Both will have painful lymphadenopathy. Herpes is caused by HSV, chancroid is caused by Haemophilus ducreyi. For herpes, you would do a Zank smear and you will treat with acyclovir. For chancroid, you will do a gram stain and you will treat with cefixime. Oral cefixime or injection ceftriaxone can also be used. Got it? Coming to LGV. LGV is different. LGV does not present with ulcer. So, you usually have a transient ulcer here which is usually not seen. Okay. What does the patient present with? Patient usually presents with inflammatory buboes here, painful, matted, suppurative lymphadenopathy is what you see with LGV. And so, here you see groove sign. So, LGV hardly see an ulcer. The organism which causes it is Chlamydia trachomatis, serovars L1, 2 and 3. This was recently asked. And the treatment is doxycycline. Coming to donovenosis can have one or more lesions which are again painless, but there is no induration. Very, very important thing about donovenosis is that these ulcers are granulomatous, they are red, beefy, granulomatous ulcers which bleed easily. So, red granulomatous beefy ulcers which bleed easily are donovenosis. There is no lymphadenopathy here, you can see pseudobubos here. So, since there are no lymphadenopathy, you can see pseudobubos here. Causative organism is Klebsiella granulomatis. What do? You do a GIMSA stain where you will see safety pin appearance. I will show you all of that. And treatment is Erythro. So, I would request you to keep this table very, very handy to revise at the end moment about all 5 genital ulcers. If you know this table, you will be able to answer almost all the questions, right. Now, I will quickly show you how do they look like so that there is an idea. So, single painless indurated ulcer, very, very clean edge, very, very clean base. This is chancre. So, chancre is how, this is how it looks like. Another thing they ask you in syphilis is this. So, they give you a truck driver or something, migrant laborer or something like this, presenting with these lesions on the palms and soles. So, and then they ask you what is this. So, this is again secondary syphilis. So this is syphlid which is presenting on the hands and feet, and you have BO sign here or Buschke-Ollendorff sign here. Clear? And this is dark ground microscopy that you see, and you see these fluorescent spiral wavy organisms here. So you do a dark ground microscopy here. Clear? So this is what is asked in syphilis. This is another very important thing asked in syphilis. What is condyloma lata? Condyloma lata are broad based flat lesions that you see on the folds of syphilis patients, which are highly infective. So they are papillary syphilid, which because of friction become macerated, leading to these broad based flat lesions which are very infected. Don't confuse it with condyloma acuminata. Condyloma acuminata, I'll show you the image. They are not broad based or they are not moist. They have a little verrucous surface to it, right? So condyloma lata, lata is syphilis, remember. Acuminata is HPV, which we will show you. Clear? So which among strain cell is most common in, there is no such strain. L1, L2, 3 are the 3 strains which are told for chlamydia trachomatis. Okay, so you should be able to identify condyloma lata. Now this is herpes. You see these coalescing vesicles, you see polycyclic erosions, the lesions may be recurrent, they are painful. You do not see an ulcer. This is herpes genitalis. And this is what you see in Zhang smear, very commonly asked, very important question, that you see multinucleate giant cells. So multinucleate giant cells are a feature of herpes genitalis. Now Zhang smear is also done in Pemphigus group of disorder, but there you will see acantholytic cells only. You do not see MNGs there. Here in herpes you see MNGs with acantholytic cells. So if MNGs are shown to you, think of herpes, and this is another important question that has been repeatedly asked. Right? What is this? This is chancroid. You see multiple painful ulcers which have a greyish slough, which are non-indurated. So this is chancroid. H. ducreyi. What do you see on gram stain? You see school of fish appearance. They are gram negative diplococci which are arranged in chain like this, and they are called as school of fish or railroad track appearance. Right? Railroad track appearance of school of fish appearance is called as. What is the culture medium which is used here? So culture medium used here is, quickly, anybody? Anybody? So Muller-Hirtan agar enriched with chocolate horse blood. So Muller-Hirtan agar enriched with chocolate horse blood is the culture medium which is used for chancroid. Now this is what? What is this? This is donovanosis. You see such a granulomatous, beefy looking ulcers, red velvety look. This is donovanosis. And what is this? This is pseudobubo. There is no lymph nodes which are seen in donovanosis. Sometimes donovanosis ulcer may be there on the lymph node, and this is called as pseudobubo. And when you do a GIMSA staining, you see safety pin appearance here. Safety pin appearance is seen in donovanosis like this. So there is peripheral condensation of the cytoplasm. These are called as Donovan bodies. Very good. Okay, so this is donovanosis. What is this? This is this is lymphogranuloma venereum or LGV. As I told you, you hardly see ulcers. You see painful matted lymphadenopathy, and you see a groove sign which is called as groove sign of green blood, because the Popot's ligament becomes taut because of inguinal and femoral lymph node involvement. So LGV presents with groove sign of green blood. Right. So these are my genital ulcers disease, and this was a very brief thing about them, but that is the most important thing. Now we will come to urethral discharge. Urethral discharge are also commonly asked. So there can be two kinds of urethral discharge. One, it may be very purulent, thick, copious discharge with constitutional and urinary symptoms. So, if the patient has purulent, thick, copious discharge like this, sometimes they just give you an image. So, this is good job. So, this is gonococcal urethritis, and it can also happen as cervicitis. So, gonococcal urethritis is always very purulent, thick, copious discharge with constitutional and urinary symptoms and a short incubation period of usually 3 to 5 days. So, all this points towards gonococcal urethritis, which is caused by Neisseria gonorrhea, right? Versus if the discharge is scanty, thin, watery, and with a long incubation period, this is referred to as non-gono. It is not gram-positive cocci, it is gram-negative cocci, yes. So, Neisseria gonorrhea is gram-negative, okay, it is gram-negative. So, this is non-gonococcal urethritis. So, you classify urethritis into gonococcal or non-gonococcal. Now, these non-gonococcal urethritis are in turn caused by either chlamydia, they can be caused by mycoplasma, HSV, trichomoniasis. So, all of this can cause non-gonococcal urethritis, and so there was once a question where they have given this image and they had asked you what cannot cause this kind of urethritis. So, Neisseria gonorrhea does not cause this. This is all non-gonococcal urethritis which will present like this: scanty, thin, watery discharge with short incubation period. Which kind of urethritis has more chances of complication? So, this has more chances of complication because it is so asymptomatic that patient does not come to treatment. So, more chances of complications here. Now, how do you differentiate it on the basis of lab? Suppose you are not clear on the discharge, you will make a gram stain. On gram stain, you would see polymorphonucleosides, right? You will see PMNs, which should be more than 5 per high power field. So, this will be there in both kind of urethritis, but if it is gonococcal urethritis, you would see this. You would see gram negative diplococci. You would see these gram negative diplococci, which are kidney shaped or bean shaped cells arranged in pairs, right? So, gram negative diplococci, and you are right, the culture medium which is used is Thayer-Martin medium for this. So, on gram stain, if you just see PMNs, that is non-gonococcal, but if with PMNs you are seeing these gram negative diplococci, you again will point towards gonococcal urethritis, right? How do you treat? So, treatment, gonococcal urethritis and non-gonococcal urethritis. So, in both of them, you give azithro 1 gram stat, but in gonococcal urethritis, in addition, you will give injection ceftriaxone or oral cefixime. Okay, injection ceftriaxone or oral cefixime, but azithro 1 gram stat will be given in both GU and NGU. Very good. Yes, you will give gray kit here, or which is the kit 1. Okay, kit 1 will be given here. Wonderful. Now, in STIs, you also should know anogenital warts. I was telling you condyloma acuminata caused by HPV. So, condyloma acuminata is nothing but anogenital wart. So, this is how it looks like. There is certain rough hyperkeratotic surface, whereas lata is broad and very smooth and moist. Now, sometimes condyloma acuminata may be giant condyloma acuminata, in which case we call it as Buschke-Lowenstein tumor. You have to just identify it, and you should know that this is associated with high risk HPV subtypes. High risk HPV subtypes, Buschke-Lowenstein tumor or joint condyloma acuminata. Okay. So moving on to the next topic, here you are given something like this. I have a patient who is presenting, I have a 40-year-old female presenting with oral erosions and flaccid bulla on body. Oral erosions and flaccid bulla on body. If I have been given this combination, there should be no confusion between bullous pemphigoid or whatever. You have to only and only think of Pemphigus vulgaris here. Be very, very clear on this topic. This is just what you need. Oral erosion, flaccid bullae, think only of Pemphigus vulgaris. Why? Flaccid bulla means intraepidermal bullae, right? And intraepidermal, we have Pemphigus vulgaris and foliaceous. Foliaceous will never present with oral lesions, so this is Pemphigus vulgaris. So painful oral erosions with flaccid bullae on body is Pemphigus vulgaris. Now, if I have this, I have crusted erosions on body with no mucosal involvement on seborrheic distribution. Then you will think of Pemphigus foliaceus. Right? So, Pemphigus foliaceus, there is never a mucosal involvement. You hardly see any bulla because here the target antigen is desmoglein 1, which is very, very superficial. So, you have here subcorneal bulla. So, these bulla are so superficial that they rupture easily. So, you hardly see anything. Here the bulla are suprabasal. Suprabasal bulla are there. Clear? So, this is Pemphigus foliaceus and that is Pemphigus vulgaris. Then what is this? Here I have a 60, I am giving you all these scenarios and then I will discuss the differences. A 60-year-old female presenting with itchy lesions and tense bulla. So, if you have a relatively older age patient with itchy lesions with tense bulla, only think of bullous pemphigoid. Because tense bulla means subepidermal disorder and bullous pemphigoid is associated with a pre-bullous stage where you see these itchy erythematous, eczematous, urticarial lesions. So, itchy lesions, tense bulla, mucosal involvement may or may not be there here. It is seen only in 30%. So, that is not relevant. Clear? Yes, you are right. So, why is there itching? There is eosinophilic infiltration here. You see eosinophilic spongiosis on biopsy. So, because of these eosinophils, the lesions in bullous pemphigoid are very, very itchy. Clear? Now, so how do you differentiate between pemphigus and pemphigoid? So, that is a quick recap. I have just shown you the images. Older age group 60 to 80 years. Middle age group 40 to 60 years. Here the bulla are flaccid, here the bulla are tense. So, pemphigoid means subepidermal disorders. Then MINAR is positive in pemphigus group of disorders. What is MINAR? Mucosal involvement, intraepidermal bullae, Nikolsky sign, acanthocytes and row of tombstone. Mucosal involvement we know is common in Pemphigus vulgaris. We know Pemphigus is intraepidermal, pemphigoid is subepidermal. Nikolsky sign is positive in intraepidermal disorders. It is not positive in pemphigoid group of disorders. What are acanthocytes? These are Zank cells or acantholytic cells which are seen on Zank smear. Again, they will be seen only in pemphigus group of disorders because Zank cells are modified keratinocytes which will be seen only in epidermis. On histopathology, pemphigus shows row of tombstone appearance which is this. There is split, there is separation of keratinocytes in the basal layer, giving rise to row of tombstone appearance. So, Minar being positive, flaccid lesions, please think of Pemphigus group. In Pemphigus group, oral erosions, flaccid bullae, think of vulgaris. No mucosal involvement, crusted erosions and seborrheic distribution, think of foliaceous. Clear? Yes, so I have put in here. Vulgaris and foliaceous target antigen. In vulgaris, it is desmoglein 3, can also be desmoglein 1, but predominantly desmoglein 3. In foliaceous, the target antigen is desmoglein 1. Split, I have told you it is suprabasal, this is subcorneal. I have told you the site here, it can be present anywhere in the body. There is skin involvement in terms of flaccid bulla, there is mucosal involvement. Here you see crusted erosions in seborrheic distribution. Any confusion in differentiating between vulgaris foliaceous or pemphigus and pemphigoid, please ask me now. It is very simple and these are the questions which are commonly asked, right? So, please ask me. Now, I am showing you certain other images which are asked. So, acantholysis means separation of keratinocytes. Separation of keratinocytes will happen only in the epidermis because keratinocytes are in the epidermis. So, they are seen in intraepidermal disorders or pemphigus group of disorders. So, pemphigus vulgaris will present with something like this. You can be given a histopath image. You see this is my stratum corneum, this is my granulosum, this is my stratum basale. So, I see a suprabasal split in the layer of stratum spinosum. So, this is a split that I am seeing and I see these row of tombstone appearance. So, this is how pemphigus vulgaris will present to you with. If you do a Zank smear, you see these modified large keratinocytes which are called as Zank cells or acanthocytes or acantholytic cells, again seen in pemphigus vulgaris and foliaceous. Then you can be given a DIF image or direct immunofluorescence image, which is the gold standard to diagnosing any immunobullous disorders. So, gold standard test to diagnose immunobullous disorders is direct immunofluorescence. In direct immunofluorescence, you see, what is this pattern that you see in pemphigus? So, this is seen in pemphigus and this is seen in pemphigoid. Quickly, I need to know the pattern. Very good. So, this is fish net pattern. So, if you see this fish net pattern like this, so this is all pemphigus. In pemphigoid, it is a subepidermal disorder. So, you see linear band of fluorescence along the dermoepidermal junction on DE junction. So, linear band of fluorescence on dermoepidermal junction is pemphigoid group, fishnet is pemphigus group. Clear on that? So, again I would say if there is any confusion, please ask me here, but these are the questions that you should be able to do it easily now. Okay, what is this? I have a pregnant female in third trimester presenting with itchy lesions and tense bulla, especially around umbilicus. So, what is this? Third trimester, pregnant patients, itchy lesions, tense bulla around umbilicus. Yes, this is pemphigoid gestationis and this is also referred to as herpes gestationis. It is a misnomer, there is no herpes here. This is pemphigoid gestationis, which is nothing but bullous pemphigoid in pregnancy. Here you typically see C3 complement deposition, which is characteristically seen in DIF. So, you see a linear band, but that linear band is mainly made of C3 complement here. So, bullous pemphigoid in pregnancy is called as pemphigoid gestationis or herpes gestationis. How do you treat bullous pemphigoid? The drug of choice for bullous pemphigoid is anybody? Before I come back here. So, what is drug of choice for BP? Anybody? Not cyclophosphamide. Cyclophosphamide is not drug of choice for anything in dermatology. I mean, you use it if I ask you the treatment of choice for Pemphigus group of disorder. There you would see, say, oral steroids and immunosuppressants, right? And in immunosuppressants, there is azathioprine, cyclophosphamide and MMF that you use. But what is the drug of choice for bullous pemphigoid? Okay. Again, rituximab is a biological that is used here. Come on, friends, give me the correct answer. I am asking for bullous pemphigoid. None of this is for bullous pemphigoid. Yes. So, drug of choice for bullous pemphigoid is Dapsone. We can use all of this that you have told me, but if you are asked the drug of choice, please say it is Dapsone. Okay? Don't get confused. Now, what is this? Here I have a 20-year-old male presenting with itchy lesions on extensors which is not responding to any treatment, and there is associated gluten sensitive enteropathy. Good job. So, you all know this. So, this is dermatitis herpetiformis. Dermatitis herpetiformis is associated with diarrhea. You give Dapsone here. So, D's, I'm putting on the D's. So, there is diarrhea, there is Dapsone which is given here. What is the target antigen, if anybody can tell me? So, what is the target antigen? It is associated with gluten sensitive enteropathy, itchy lesions on the extensors. The target antigen. Yes. So, there is papillary tip IgA deposition. So, on the papillary tip you see IgA deposition. You are absolutely right. The target antigen here is epidermal transglutaminase. Epidermal transglutaminase is the target antigen here. So, it also comes under the category of subepidermal disorders, but it is different because here the target antigen is different. Gluten sensitive enteropathy is there. There is no bulla that you see. There is no mucosal involvement. There are just itchy lesions on the extensors, which when you biopsy, you see papillary tip IgA deposition on DIF, right? Or you can even see papillary microabscesses on histopathology. And I am sure you know the treatment. In treatment, you have to avoid Dapsone. You have to give Dapsone, I am so sorry, and you have to avoid gluten. And when you say that gluten is to be avoided, you mean you need to avoid bro, which is barley, rye, oats and wheats, out of which oats is safest. You should know this. Oats is safest, but you can take maize and rice. MR is allowed, bro is not allowed. Okay. So, I know you know all of this, the treatment you all know, but remember all these important points about dermatitis herpetiformis because this is again an important topic, right? I am coming on to the next topic, which is hair, and I am quickly moving on because the time is running and we are still left with some of the important topics. So, what is this? So, you have smooth patches of alopecia in a patient. It can be single, it can be multiple patch, but you see the patches are very, very clean. You can see grey hair on the periphery. So, this is, as you rightly pointed out, this is alopecia areata. So, alopecia areata presents with smooth patches of alopecia, no scaling, no redness, no itching, very, very smooth patches. You can see some grey hair on the periphery. Patches can be single, they can be multiple, and you see, if you do a trichoscopy, you see exclamation mark hair on the periphery. exclamation mark here are seen on the periphery. Now remember, alopecia areata is an autoimmune disorder. So the patient may have other associated autoimmune disorders like thyroid issues or pernicious anemia. Right? What is the treatment that you do for this? Alopecia areata, the treatment is you give intralesional steroids. Intralesional steroids are given as the treatment of choice for alopecia areata. What do you see on histopathology? You see swarm of bees appearance. What do you see on nails? You see regular pitting. No minoxidil here. Alopecia areata is not treated with minoxidil. Please don't mark minoxidil here. It is treated with intralesional steroids, or if extensive, you have to give immunosuppressants. You can give contact immunotherapy, but minoxidil is not the treatment that is used for alopecia areata because it is an autoimmune inflammation. The patient can also go grey overnight here. So, turning grey syndrome is also a feature of alopecia areata. Turning grey syndrome, because grey hair are not targeted in alopecia areata. So, the patient can turn grey overnight. Yes, you are right. So, aminoxidil and finasterides are used for androgenetic alopecia. So, what is this? I have a maybe 16-year-old male who is socially withdrawn. The the parents give history that he stays within himself, and you have a patchy alopecia. So, when you see this, what do you have to identify? Very good, this is trichotillomania, and this is trichotillomania because you are seeing hair shafts of various lengths. So, when you see hair shafts of various lengths, you have to think of trichotillomania. It is a psychiatric disorder which happens because of habitual pulling of the hair. So, there is habitual pulling of the hair, and because of that habitual pulling, there is a patch of alopecia, but it is not a smooth patch. There is no scaling like in Tinea capitis. You do not see black dots, but what you see is you see hair shafts of various lengths. So, in alopecia areata, smooth patch, exclamation mark here. Tinea capitis, either grey scales, itching, or in black dot you see black dots. In trichotillomania, patchy alopecia but hair shafts of various lengths being there. So, this is trichotillomania, and here you have to treat it with antipsychotic medications with cognitive behavioral therapy. And here there can also be trichophagia, patient may be eating the hair, which can lead to trichobezoar or GI obstruction. Clear? Moving on. What is this? I have a 40-year-old male who's a smoker, diabetic, presenting with multiple painful lesions on underarms which are recurrent and heal with scarring. So, I have given you all the important features in the question. Yes, this is hidradenitis suppurativa, not malaria. So, malaria, no worries, don't worry if you're giving wrong, this is the time to make mistakes. Malaria rubra is prickly heat. It will present with very small, red, itchy, irritative papules, mostly on the back, chest, in the areas where you sweat more. This is underarms. You are seeing these abscesses, you are seeing folliculitis. So, when you see these abscesses, folliculitis, and they are healing with bridging scars, and I am telling you that the patient is smoker, diabetic, because these are the patients in which you see this, and you have multiple painful folliculitis like lesions, abscesses, nodules which are recurrent, which heal with scarring. So, this is, you are right, this is hidradenitis suppurativa, which is a disorder of which gland? Hidradenitis suppurativa is a disorder of apocrine gland. Apocrine gland, not sweat. Okay, a type of sweat gland, but sweat glands are two, eccrine and apocrine. Apocrine is not the major sweat gland. Eccrine sweat glands are major sweat glands. So, you have to specifically say that this is a disorder of apocrine gland, right? And this is the criteria. You see this lesions. Typically, apocrine glands are present in axilla, perianal areas, groin, inframammary fold. So, these are the areas where you will see these lesions, and these lesions tend to recur. So, you should be able to identify hidradenitis suppurativa. What is this? This is just an image that has been provided to you. You have to tell me what is this. Very good. So, these are Fordyce spots. Fordyce spots are nothing but ectopic sebaceous glands on lips. So, ectopic sebaceous glands present on the margins of lips, oral mucosa, these are called as Fordyce spots. We should know what is Fordyce disease also. So, Fordyce disease is apocrine malaria. So, malaria of apocrine gland usually seen in adolescent females. On the underarms, you see these skin colored papules which are itchy, that is Fordyce disease. Fordyce spots is this is what you see as ectopic sebaceous glands. Okay. Moving on to the next disorder, which is psoriasis. As you can see, in psoriasis, know few things. If you have silvery white scales anywhere, silvery white scales, think of psoriasis. So, erythematous indurated plaque with silvery white scales. Yes. So, you write about apocrine. Now, we are back to psoriasis, erythematous indurated plaques with silvery white scales, think of psoriasis. In psoriasis, you should know that Auspitz sign is positive, where you see pinpoint bleeding point. So, there is accentuation of scaling, there is a Berkeley's membrane, and then there are pinpoint bleeding point which are seen. So, Auspitz sign is seen in psoriasis, silvery white scales are seen in psoriasis. Next thing that you see in psoriasis is Koebner's phenomena. Koebner's phenomena is if you scratch, you develop lesions of similar morphology on the areas of scratching. Here know that there is true Koebner's and false Koebner's. True Koebner's seen with psoriasis, lichen planus and vitiligo, and false Koebner's seen with molluscum contagiosum and warts. So, Koebner's phenomena Gretach test is also used in psoriasis. So, just know that the first stage of Auspitz sign is Gretach test. So, if both are given in the question, mark Auspitz sign. So, Gretach test is a part of Auspitz sign. Okay? Yes. So, true Koebner seen with psoriasis, lichen planus and vitiligo. False Koebner seen with molluscum and warts. This is also called as pseudo Koebner's because here it happens because of auto inoculation of microorganisms. Right. Now, what is this? Now, when I am talking about psoriasis, you should know about the nail changes in psoriasis. So, nail changes in psoriasis. Wonderful. Good. So, the most common nail change is pits. Now, I also told you pits were also seen in alopecia areata. What is the difference between pits here? Here the pits are more deep, they are random, they are irregular and they are large. So, they are not regular pits here, right. So, most common finding of nail in psoriasis is pits, but the most specific finding, as someone already pointed out, is oil drop sign or salmon patch. Oil drop sign or salmon patch is the most specific finding. So, what is this oil drop sign? This. So, you see a reddish kind of a plaque with distal onycholysis or yellowish discoloration. So, like an oil is present beneath the nail plate. So, oil drop sign, also called as salmon patch, is specific, and pits are the most commonest finding in nails. Then in psoriasis, they ask you about histopathology and you should be knowing about that. So, what are the changes in histopathology? In stratum corneum, you see hyperkeratosis, you see parakeratosis, and you see Munro's microabscesses. So, what are Munro's microabscesses? These are collection of neutrophils, but they are present where? In the stratum corneum. So, Munro's microabscesses, collection of neutrophils seen in psoriasis, present in stratum corneum. Stratum granulosum is absent here. So, there is agranulosis. Stratum spinosum shows acanthosis and another collection of neutrophils, but here it is called as Kogoge spongiform pustules. S, so S for spinosum, S for spongiform. Right. So, Munro's microabscesses is in stratum corneum, Kogoge spongiform pustules is in stratum spinosum. Then you see elongation of rete ridges and a camel foot appearance of the rete ridges. In the dermis, there is suprapapillary thinning, dilated blood vessels and inflammation. Now, remember a very, very important thing in psoriasis. The first change in psoriasis occurs in dermis. So, this was a question once where they asked what would be the first change that you would see in psoriatic histopathology. And these were the features given, and one of those features were given, inflammation. So, remember the change happens in the dermis and then it goes up to the epidermis. So, first change is inflammation which is happening in the dermis. Don't forget that. Okay. What is this? This is also a type of psoriasis which you should be knowing. Here I have a child who has recurrent sore throat presenting with small scaly lesions on trunk. Wonderful. So, this is guttate psoriasis. Guttate psoriasis is seen in children. Patient usually have an underlying streptococcal infection. Typically, trunk is effective and there is raindrop appearance. And because there is an underlying streptococcal throat infection, the treatment here is antibiotics, very commonly asked. They give you this clinical picture and they ask you how will you treat. Now, psoriasis, you don't treat with antibiotics, but this is an unusual psoriasis which is treated with antibiotics because streptococcus is considered an important carriage here. In fact, you can also go for tonsillectomy, right? So, this is guttate psoriasis. Now, few more images, few more questions which are asked. This is a common image which is given. They ask you what it is. At birth, single hyperpigmented lesion showing hypertrichosis, showing rugosities. This is congenital melanocytic nevi. Congenital present since birth, melanocytic because it's black, but when do you call it as CMN? When you have a single hypertrichotic lesion showing rugosities present at birth, very, very black looking lesion. This is not nevus of ota. I'll show you nevus of ota. Nevus of ota is bluish in color and nevus of ota does not have hypertrichosis. So, remember this, hypertrichosis, black colored lesion is CMN. Okay. Now, when the CMN is very, very large, can cover most of the trunk, it is called as garment nevi or bathing trunk nevi. If you see more than 20 centimeter of lesions and you see these satellite lesions, this will have propensity to develop melanoma in later life, right? So, you have to counsel the patient. This has malignant potential if the CMN is very large and if there are satellite lesions which are present. Okay. So, this is nevus of ota. Nevus of ota is present one around the eyes which was there. So, it is present around the trigeminal nerve. So, ophthalmic and division of trigeminal nerve. And that is why it also called as ophthalmico-maxillaris, because ophthalmic and maxillary division of trigeminal nerve is the area where it is present. It is presenting with a bluish hue because it is a dermal nevi. And you see these speckle changes, you see iris being involved. So, this is nevus of ota, also called as nevus fusco-ceruleus ophthalmo-maxillaris. The only treatment here is lasers. And what do you use? Lasers, alexandride, ruby, or Q switched. Right? Yes, this is also unilateral, absolutely right. So, unilateral nevi giving a bluish hue with some brownish pigmentation, also involving the eyes. This is nevus of ota, and you should be able to identify this. Now, another important nevi which is asked is nevus depigmentosus. So, nevus depigmentosus is another nevi which present with usually single hypopigmented lesion which is present anywhere in the body, can be on the trunk, can be on the legs. Now, nevus depigmentosus needs to be differentiated one from nevus anemicus. Nevus anemicus, how do you differentiate nevus depigmentosus and nevus anemicus? I have only been talking. Tell me, how do you differentiate nevus anemicus from nevus depigmentosus? Anybody? Anemicus, you are right, is caused by vasoconstriction. It's a pharmacological nevus. So, you differentiate it with the help of dioscopy. On dioscopy, nevus anemicus will verge with normal surroundings, whereas nevus depigmentosus will remain unchanged. Then sometimes you have to differentiate it from vitiligo, which may be congenital. Now, nevus depigmentosus usually does not present at birth, but a little later, right? Now, if you have to differentiate it from congenital vitiligo, remember vitiligo is completely depigmented, whereas depigmentosus is hypopigmented. Vitiligo on Wood's lamp would turn completely white. So, there will be accentuation on Wood's lamp, and vitiligo can progress, whereas nevus depigmentosus is hypopigmented. Usually on Wood's lamp there is only mild accentuation that you see, and it is usually restricted to that particular area, it does not increase, right. So, this is what you need to differentiate. Then this is a type of vitiligo which is very commonly asked. This is called as segmental vitiligo. Now, segmental vitiligo presents with this, a vitiligo-like lesion which is present along a segment. It is different from normal vitiligo because it is believed that this is because of some transmitters released along the nerve which causes loss of pigment in that area. So, because of that, it is limited to this particular area and so have a relatively stable course. There is frequent association with leukotrachea. There is no Kobner's phenomena because you do not usually see activity, and this responds usually to surgery. It does not respond to medical treatment or phototherapy, because you have to understand that here it is not the role of autoimmune mediators, it's mainly it supports the neurogenic hypothesis of vitiligo. So, segmental vitiligo you should be able to differentiate or identify. Yes, it is unilateral because it is along a segment. Okay, then since we are talking about vitiligo, there can be other causes of depigmented lesions. So, there is something called as contact leukoderma that you should be knowing about. So, sometimes contact leukoderma is because of contact with a chemical, the patient develops depigmented lesions here. So, this is because of rubber chappals. Rubber has monobenzyl ether of hydroquinone which causes depigmentation. This is at the site of bindi. In bindi, what is there? You already told me, para-tertiary butyl phenol which can cause bindi dermatitis or also contact leukoderma due to bindi, right. MBEH in slippers because slippers have rubber. So, this is what you should be able to identify. Then moving on, there you are commonly given these images where a patient comes in contact with certain metals in the form of buckles, ring, some artificial jewelry, wrist watches, and this, the most common metal causing this is nickel, and this is nickel induced contact allergic dermatitis. Nickel induced contact allergic dermatitis. Nickel is the most common metal which causes contact allergic dermatitis. And you are right, contact allergic dermatitis happens because of type 4 hypersensitivity reaction, right? Then even hair dye can cause contact allergic dermatitis because hair dye contains paraphenylene diamine. These agents are asked, that is why I am telling you. Bindi, I already told you, para tertiary butyl phenol. So, on hair dye we have PPD, bindi we have PTBP. In metals, nickel is the most common cause which causes contact allergic dermatitis. To identify an allergen, we do a patch test. Patch test is a type of type 4 hypersensitivity reaction. It helps me identify the allergen. It is put on back. I will not explain the whole process of patch test. You should know when is the patch test read. It is read at 48 hours and 96 hours. 96 hours would be the best time because there are certain delayed reactors. So, to identify the allergen, you do a patch test. You should know it is a type 4 hypersensitivity reaction and it is best read at 96 hours. But if in the question you are given 48 and 96 hours, mark that. Clear? Wonderful. What is this? I have a child who has a history of asthma in family and presents with eczema or itchy lesions. So, yes, if I give you a history of asthma, if I give you a child and if these images are given, so this is face, this is flexures and this is hands. So, all of these are different manifestation of atopic dermatitis at different ages. So, atopic dermatitis in infants will present on face and extensors. In toddlers, you would see more of flexural involvement. In adults, you would see more of hands being involved. So, any of these images being given with history of atopic triad. What is atopic triad? Family or personal history of either hay fever, asthma or atopy. Family or personal history of hay fever, asthma or atopy, any atopic triad being given, itching being given, these sites being given, think only of atopic dermatitis. What is this? This is also commonly given with atopic dermatitis. So, they give you this, they can give you a child who has history of asthma or there is a family history of asthma and this sign was noted by the practitioner. So, what is this sign? This is an extra fold of skin which is called as Denny-Morgan fold. Denny-Morgan fold is a feature of atopic dermatitis. So, usually you will be given any of this history with this. So, you are right. Hannifin and Rajka criteria is used for diagnosing AD. The patient must have itching, patient must have typical morphology and distribution, the lesions should be chronic, relapsing, remitting and there is a personal or family history of atopy, hay fever, asthma or atopic dermatitis. So, this is the criteria and it helps us to identify atopic dermatitis, another common question which is asked in the exam. Now, quickly I will just show you the images and you have to identify what are these. So, what is this? I can give you a brief history if you want, but let me see if you can identify what is this condition. Amazing, you guys are amazing. Yes, so this is dermatomyositis. Dermatomyositis, the patient will have proximal muscle weakness typically and in skin. These are the findings which may be given. So, this is Gottron's papule. What is this? Nobody gave me an answer to what is this. Oh, you have already given, good. This is Gottron's sign and this is heliotrope rash. Heliotrope rash. So this is all dermatomyositis, proximal muscle weakness with skin features which are Cotron's papule, signs, heliotrope rash, and you are right, there can be mechanics hand also. Typically, these patients will have proximal muscle weakness with these skin findings. Yes, there can be shawl sign, there can be other things. Okay, next. What is this? So, I have a child, a 4 to 5 year old child presenting with these erythematous lesions, raised papules on the cheeks, on the nasolabial fold. So, these are adenoma sebaceum, also called as cutaneous angiofibromas. And where do I see this? Yes, I see this in tuberous sclerosis. So, tuberous sclerosis will typically present with adenoma sebaceum, which looks like this. This is not acne, they are monomorphic erythematous papules which are present on the cheeks, nasolabial fold and nose. This is adenoma sebaceum and this is seen with tuberous sclerosis. What else can you see with tuberous sclerosis? You see these ash leaf macules. You can see shagreen patch or collagenoma. And you see, what is this? Let me see. Oh, you've already given me the answer. You see Keenan's tumor or periungual fibroma. So, all of these are features of adenoma sebaceum in skin. Apart from this, you see rhabdomyosarcomas, you see cardiac hematomas. So, you have lot of hematomas in tuberous sclerosis. What is the chromosome involvement in tuberous sclerosis? What is the chromosome involvement in tuberous sclerosis? Anybody? Yes, so chromosome 9 and 16 is involved, and you are right, there is associated epilepsy, low intelligence and adenoma sebaceum. So, epiloia is the thing. Okay, 9 and 16 is the chromosome here. Then you are given an image like this where you see periorificial lentigenes. So, if you see lentigenes along the orifices, around the oral mucosa, think of Peutz-Jeghers syndrome. Peutz-Jeghers is associated with underlying gastric polyps, and the gene which is involved here is STK11. So, STK11 gene, gastric polyps being present, periorificial lentigenes. These patients require regular endoscopic examinations because they are prone to underlying gastric carcinoma. So, you are given this image and you are asked what is this. So, this is Peutz-Jeghers. What is this? The patient has recurrent vesicular eruptions in the intertriginous areas associated with maceration, exacerbations, remissions, chronic course, no mucosal involvement. All the history has been provided. Anybody, what is this? Recurrent vesicular eruptions in the intertriginous areas with frequent exacerbations and remissions. Chronic course. Pemphigus foliaceus does not present in the intertriginous area. So, this is Haley, absolutely right. So, this is Haley disease, which is an inherited acantholytic disorder which presents like this. The typical thing that is associated with Haley is, if you do a histopath, you see dilapidated brick wall appearance. Dilapidated brick wall appearance is associated with Haley disease, and I told you Haley also has disc keratosis, right? Then next, what is this? Let me see what all images. Yes. So, when we move on to ichthyosis, you should be able to differentiate between three main types of ichthyosis. Ichthyosis vulgaris, which usually presents with extensors on extensors, or X-linked recessive ichthyosis, which is seen more only in males. You have this dirty looking scales which typically affects flexures and preauricular area. Ichthyosis vulgaris extensors seen in atopic gray scales. This is the most commonest. XLRI seen in males, dirty looking scales present in flexures and preauricular area. What is this? Anybody? What kind of ichthyosis is this? I am giving you a hint with this. Wonderful. So, this is lamellar ichthyosis because there is associated colloidal membrane. So, if a child is born in colloidal membrane, there are high chances that the child will develop lamellar ichthyosis, which typically has fish-like or plate-like scales. Okay. So, fish-like, plate-like scales with colloidal membrane is lamellar ichthyosis. Okay. So, ichthyosis vulgaris defect is filaggrin. I already discussed this. XLRI defect is in steroid sulfatase genes, and in lamellar ichthyosis the defect is in transglutaminase. This presents at birth with colloidal membrane. Okay. Now, few other images. This is given. You are given an image of an elbow showing hyperkeratotic rough papules. There may be history of night blindness. So, night blindness with these hyperkeratotic papules on the elbows. This is phrenoderma, usually associated with vitamin A deficiency, but can also be seen with other essential fatty acid deficiencies. Right? Next, what is this? Another very common nutritional deficiency which is asked. So, you have subacute eczematous lesions which are present in photo-exposed areas. Very good. So, this is pellagra. Pellagra is associated with 3 Ds: diarrhea, dermatitis and dementia. Diarrhea, dermatitis and dementia are the 3 Ds which are associated with pellagra, and you see this which is Castle's necklace appearance. Pellagra is also very common with commonly asked. Commonly seen in chronic maze eaters, in alcoholics and in patients with heart nerve disease. Okay? Yes, the 4th D is death. So, if you do not treat, the patient can die. Chronic maze eaters, alcoholics and heart nerve disease. Another image which is given to you. So, you see this, you have velvety texture, hyperpigmented texture which can be present in the neck, can be present in the axilla. This is acanthosis nigricans associated with obesity, insulin resistance, diabetes mellitus, metabolic syndrome. So, all of this can lead to acanthosis nigricans which presents with this hyperpigmented velvety lesions on the flexures. Now, sometimes acanthosis nigricans can also be malignant AN. Malignant AN is when it acts as a paraneoplastic dermatosis. When you have extensive AN all over the body, there may be an underlying gastric carcinoma which may be associated. Right? So, acanthosis nigricans can be benign or malignant, not in itself malignant, but pointing towards an underlying malignancy or a paraneoplastic syndrome. What is this? Another common image which is given, very commonly given. An old male presented with this lesion on the medial angle of the eye. Yes, this is basal cell carcinoma. Please know how to identify this. This is basal cell carcinoma, rodent ulcer, typically at the, okay. Somebody said cluster of jewels. You have to tell me, where do you see cluster of jewels? This is not cluster of jewels. And you removed it. That's okay. The cluster of jewels is seen in CBDC or linear IgA disease. Okay. This is an ulcer with overhanging margins, which bleeds easily, which bleeds to touch, which has telangiectasias, which has thready margins. So, this is basal cell carcinoma. Okay. Cluster of jewels is CBDC or linear IgA disease. What is this? Hyperpigmented lesions seen in adolescent male with hypertrichosis, not present at birth but starts at adolescent age group. So, not CMN. CMN was at birth, strictly unilateral. So, this is Becker's nevus. So, Becker's nevus is different because Becker's nevus presents in adolescent age group with hyperpigmented lesions which shows overlying hypertrichosis. What is this? I have a 2-year-old child who's presenting with constant itching. When I examine, I stroke my pen and I see this erythema along it. 2 years old child presenting with these itchy nodules on the trunk showing a particular sign. So, this is Urticaria pigmentosa, not urticaria, but Urticaria pigmentosa, which is a type of mastocytosis, and this sign is called as Darier's disease, Darier's sign. Darier's sign is not a feature of Darier's disease, it is a sign of Urticaria pigmentosa, which is a type of mastocytosis usually seen in 2 years old child presenting with itchy lesions, which if you stroke, it produces urticarial wheals because of release of mast cells. And I think that's where we end. So, I will wait for your questions if there are any. I hope you enjoyed the sessions. I mean, there is a lot more that can be taught, but in 2.5 hours, this is the best I could do. I have tried to pick out all the important topics which have been repeatedly asked, but I know the examiners are getting smart. They give you more and more questions from here and there. But believe me, whenever I look at the exam, almost 80 to 85% of paper is from this. So, there may be few things here and there, but mostly we have covered. And I was very glad at good answers that I received. You knew all, I mean, I got answers for almost all my questions. So, I'm very, very happy with your preparation. Keep doing like that, and I'm sure you'll come out with flying colors. And I'm here if I'll wait for a few seconds. If you have any questions, I'll be willing to answer that before I wind up. Thank you so much everyone for being patient listeners. And I wish you all the very, very best, and I'm sure you'll do very well in the exam. Okay, so I see no questions. That means everything is clear. Thank you so much, and I'll wind up the session here.